Greetings and welcome to Writers on Writing with your host, Dr. Brenda Greene. Writers on Writing is paid for by Medgar Evers College, and we come to you each Sunday and give you, our listening and viewing audience, an opportunity to hear writers from the African diaspora talk about their work, their craft, and their lives. And I'm very, very pleased to have with me Dr. Uche Blackstock.
Thank you.
Welcome, Dr. Blackstock.
Thank you, Dr. Greene. Thank you for having me.
Okay, thank you for allowing us to hear your story and for writing this really important story. Dr. Dr. Blackstock is the author of the memoir Legacy: A Black Physician Reckons with Racism in Medicine. Very, very powerful book, very compelling story, very inspirational. In fact, it was one of the books for the Center for Black Literature's
Yeah.
book club.
Thank you. I saw that
So,
earlier this year. Thank you.
yes. And so I just want to start as when I wrote the review, I kept thinking about Harriet Washington's book, Medical Apartheid.
Mhm.
And she says, of all the forces of inequality, injustice, and health is the most shocking and the most humane. And I think you really illustrate that so well in your memoir. So this story ends up being about your journey as a Harvard medical school student, a emergency room physician, a director of diversity at NYU, and then your current experience as a strong advocate on health inequities. So I'd like to begin by asking you what you think, what motivated you to share this story? Because it's also a story about your family and your mother,
Yes.
who's a
Yes.
doctor, and your sister, and there's so many
Yes.
first people in your family.
And so many layers to it. So I feel like on its surface, it's a memoir, and it's a memoir about my family and being a second generation Black woman physician, but also I wanted to use the book as an opportunity to really look at the history of racism in medicine and then help readers to connect the dots for why in 2024 we still see the horrific racial health inequities in this country that we see.
Okay, so that's part of why you wanted to write it. But it also, as I said, is a story about your own family and your mother. Why don't you share with
Yes.
us how that was impactful in helping you to tell that story?
I had this experience growing up here in Brooklyn, in the late 1970s. Where, my mother was a physician. That wasn't something that many Black children could say. And even today, that's still not something many
Yes.
Black children can say. Less than 6% of all physicians today are Black, less than 3% of them are Black women, right? So my mother was, in essence, a unicorn. But of course, as a child, you don't really appreciate that. Your mother is just your mother. But
Yes.
I was surrounded by Black physicians growing up, Black women physicians, people who at the time lived in the same communities where they were seeing patients, they were caring for their neighbors, their family, and friends. So that was the kind of environment that I was around. And my mother, as you mentioned, she was a first. She was the first person in her family to go to college, the first person in her family to go to medical school. And she grew up about 15 minutes from where I am now. She grew up, the child of a single mother. She had five other siblings on public assistance. They had a very, very difficult life, very challenging life. So the fact that my mother was able to find herself at Harvard Medical School in the mid
Yes.
70s was really against all odds.
Yes, that in and of itself is a very compelling story. One of the things that really struck me is the report that you reference, the Flexner report, and how that report had such a major impact on the number of Black physicians who were able to attend college, the medical institutions. Tell us about that report
Yes.
and the impact of that report.
It was very important for me to include a discussion of the Flexner Report in this book because people need to understand that when we talk about that 6% of physicians being Black today, there's a reason. And it's not because there's anything inherently wrong with us. There was a policy, in 1910. It was a report that was commissioned by the American Medical Association, which is the oldest and largest organization of physicians, mostly white, and they have had their own storied, troubling past with racism. And they and Carnegie Foundation commissioned an education specialist named Abraham Flexner to go around to all 155 US and Canadian medical schools and to assess them and to hold them against the gold standard of Western European schools, as well as in the US, Johns Hopkins. Now, of course, in the early 1900s, there were only 7 Black medical schools at the time. The findings in that report led to the closure of 5 out of 7 of those Black medical schools. By 1905, they had trained about 1,500, educated rather, about 1,500 Black physicians because we couldn't attend predominantly white schools. So those schools were very important. It's estimated if those 5 schools had remained open, that they would have trained between 25,000 and 35,000 Black physicians. When I heard that number, when I read that number, I cried because thinking about the loss of brain potential, that's what racism does, about the number of patients those physicians could have cared for, also the research they could have done. It is such a profound loss for our community, and it's one of the reasons why we have such a small percentage of Black physicians now.
Yes, it's and most of so many physicians who are in our major hospitals are not from this country.
And there's that part too. And so what we've seen and we still see today is that especially among Black American students, Black and then Black male students, it's very small percentage.
Right. It reminds me of what happened after schools were desegregated in Brown versus Board of Education, where we had students who were being educated in Black schools by Black teachers. But after desegregation, it just backfired because all of these teachers lost their jobs. There are so many Black teachers who lost their jobs, and the schools that many of the Black students who were in did not change that much. And we still have a segregated school system.
Right, right, right. In New
Yeah,
York City, right? One of the most segregated
that's
in the
right.
country.
That's right. So one of the things you talk about also is that one zip code really is a much bigger determinant of health outcomes than one's DNA. Can you elaborate on that? I just found that really, really an
Right.
important statistic.
So it's interesting. So even when you look at the neighborhoods that were redlined in the 1930s, even here in New York City, those are the same neighborhoods today if they haven't been gentrified with the very worst health outcomes. And so we have parts of the country even today where probably half a mile difference in distance and a 20-year difference in life expectancy. And I think it's so important for people to understand that like where you live has such a big impact on how healthy you are. And the reason being is that if your community is deprived of resources, so if you are deprived at the opportunities for home ownership, if businesses don't want to come to your neighborhood and jobs don't come, if grocery stores don't come, right, for healthy foods, if what goes towards funding property taxes, I mean, sorry,
Right.
what goes towards funding schools, property taxes, we call all of those the social determinants of health. All of those determine how healthy communities are, all those factors. And so what we've seen is that the legacy of racism, of housing discrimination in this country actually has a bigger impact on health than someone being able to even just access healthcare.
Right.
80% of what makes someone healthy, it's like 80% of it is systemic factors.
Right. And I don't, again, that's not something people traditionally think about. but it's really key. And you give some examples of people who've really been victims of that when you, of course, the Henrietta Lacks story. You want to talk about that. And then
Yes,
Jordan had sickle cell anemia. Some parts of it, I almost wanted to cry, some
I
reading
know.
some parts of
I
this.
I know. I feel like, Henrietta Lacks was someone that I had not heard about until I finished medical school. And I found out that we had been using her cancer cells in my first year medical school class, but there was no context given for who those cells came from.
Right,
And so, Henrietta Lacks was a young Black mother from impoverished Baltimore, who, in the middle of last century, who presented to Johns Hopkins Hospital with some abdominal pain and some bleeding, and was diagnosed with having uterine cancer. And her cells were taken from her without her consent,
right,
and then used not only by Johns Hopkins, but then you know um, some biopharma research companies also got a hold on it, and her cells have been used in multiple research projects in the development of the polio vaccine. I mean, the contributions to science are just profound, but the fact is that she never gave consent. Her family was never notified because she ended up passing away, that the cells were being used, and they never received any compensation up until relatively recently. And so I
mm,
think that was just like the what an utter betrayal of not only an individual but a family and a community. And when people talk about medical mistrust, I talk in the book about how that burden should not be placed on the community members. These institutions have proven themselves untrustworthy to us.
mm. And then you saw other examples of that in the medical.
Right. Jordan.
Yeah,
Yeah.
Jordan.
Yes. Sorry, go ahead.
No, go on, Jordan. I was
No, no, my patient Jordan, who I cared for while I was in residency, who had sickle cell anemia. I mean, his case just emphasized to me how broken our healthcare system was. He was someone who came to the ER very, very often because he was in pain crises, which happens often with patients with sickle cell disease. And because sickle cell disease has been racialized as a Black disease, it affects people from all over the world, from the subcontinent of India, from the Middle East, but also from sub Saharan Africa. But because most of the people in the US who have sickle cell disease are Black, this disease has not been it's been described over 100 years ago, but literally not until recently was there more than one treatment for it. And there are no centers of excellence for sickle cell disease.
right.
So many of these patients, they don't get the outpatient care that they require and need, so they end up coming to the emergency department, which is not the place that you ideally should be, but they end up coming there with complications, asking, with pain crises. And then because they are mostly Black, they are stigmatized as drug seekers, pain seekers, and mistreated. So you go from being ignored systemically, mistreated systemically, to being mistreated interpersonally. So it's just layers of harm being caused to our patients.
Right. And I think your description of the two emergency rooms really really shows and illustrates the extremes and what that looks like.
Yes.
And I kept thinking about the emergency rooms that I've been in Kings County, versus going to NYU. Can you talk a little bit about that and how that impacted you, what you saw and how that impacted you, and really was another major factor in transforming what you decided
Yeah.
to do.
Yeah, and it's interesting because growing up, my mother had worked at Kings County, so I had been at Kings County, but not as a practitioner, not as a patient, just sort of visiting her. And then for medical school, I was at Harvard, and I saw these beautiful teaching hospitals. I couldn't believe it. But part of the reason why I didn't want to stay there for my training is because I barely saw any patients that looked like me. I
Right.
barely saw any physicians that looked like me, or nurses. And I was just like, I want to go back home. So I did my emergency medicine training at Kings County, And it was there that really everything kind of sort of hit home, so to speak, and not to be redundant, but I recognized that what I was seeing in my patients who were coming to the ER, the disease and illness was a manifestation of what was going wrong in our communities, or our
Yes.
communities not being supported, not being invested in. So that's what and so that helped me connect the dots. And then when I went to NYU after that, when you're on faculty there, you work both at Bellevue and at the NYU, a mere 2 blocks apart, but a world of difference. Bellevue being a public hospital, NYU being a private hospital, the same faculty, same staff, but the resources were profoundly different and disparate. Like, you couldn't believe it, and the patients that sought care there, right? So we have patients that were uninsured or underinsured went to Bellevue, patients with the best insurance go
Right.
to NYU, and you just saw that there were always enough nurses at NYU. There was always, more than one CAT scan. No one had to wait. It was sort of like a breeze. Things just happened there. Whereas at Bellevue, the public hospital, felt like it was an uphill battle. It just felt so unfair for the patients and for the staff too.
Right. And so that as I said, that you had a sense of consciousness, and you did not want to remain in that kind of environment. But then you thought you could help by becoming diversity.
I know. How silly of me. How silly of me. I mean,
And
okay,
that exemplifies what that's across the board in academia. It's
yeah.
it's in the hospital, but that's across the board. So
Like, tell me, what do you mean across the board?
so that happens in academia, in private universities. It's not just in the medical school. Whenever
Okay.
you have diversity officer, they
Yeah.
come in with this vision and these great intentions. And then there are all these factors, and they realize that they're the symbol, so that
Yes. It's
very
just
often the organization can say, we're addressing diversity.
yes.
Yes.
So I was 7 years into my faculty position there, and I was so excited to be handpicked for this DEI role in the Office of Diversity Affairs. I was so excited. And, weeks into it, I realized that it really was just a figurehead role, that they didn't expect me to do anything. And when I tried to actually do work, I was silenced and muzzled. And that was just it was incredibly demoralizing. And for me, that combined with, I also around that time had gone up for promotion to associate professor, and everyone told me I was a slam dunk. And my department voted for me unanimously to go up, but the institutional promotions committee said no. Basically, whatever the work that you've done is not good enough. And those two experiences really pushed me to say, you know what? I don't need to deal with this. I need to get out of here. And in that internal conversation with myself, I thought about academia. I thought about, should I stay in academia? One thing I didn't put in the book, but what happened was I actually was offered associate dean of diversity at Harvard Medical School.
Okay.
And I said, I'm not gonna do it because it's gonna be more of the same. And I just need to, I think I'm in the season where I need to do things my way. And so before I left, I founded my company, Advancing Health Equity. And I said, I'm gonna do it my way. And so I founded my own consulting firm. It's gonna be 6 years old in March.
Okay. So tell us about that.
Yes, Advancing Health Equity. It's a strategic health equity consulting firm, and our mission is to eliminate bias um, and discrimination in healthcare and medicine. And so we work with healthcare and healthcare adjacent organizations, anywhere from hospital systems to departments of health. We go in, we do everything from trainings to audits, assessments, capacity building, strategic planning. We help them these are organizations that want help on their health equity journey, because I recognize it's so important for them to create workplaces where a diverse pool of people feel comfortable, but we know that also trickles down to the care that they're providing to patients. And so we've had over 100 different clients. We will see what happens over the next year or two, given the incoming administration, because we've already seen some of our clients have said, "Oh, we can't use this
The
term
term.
anymore. We can't
Yes,
use that term anymore." So it's interesting because for me, the fact that Legacy, it's going to be a year since Legacy was first released, I almost feel like it's more timely coming out now with this
I agree.
incoming administration than it was earlier in the year when it was still very relevant, still timely, but I feel like there's more of an urgency now.
No, I agree, and because it's obvious when you look at what happened in this election that there's so many people who are not really aware, who are only looking at things on the surface and who do not understand that whatever happens affects Black people, but affects everyone.
I know.
It's an
I know.
indictment of the entire system,
Yes.
and they're going to see it. They're
I
going to
really
feel it.
I really hope they do. And it's so interesting that you say that because when I talk about health outcomes in the United States, right? When we look at life expectancy, maternal mortality, compared to our other high income peer nations, we do very poorly. And it's not
Yes,
just, and it's everybody, it's every racial demographic group. It's even white Americans. They're not doing well. Life expectancy for them compared to in Western European countries, they're not doing well because we have a healthcare system that doesn't really, it's a for-profit system. It's decentralized. Right? We have a lot of people who don't have access to healthcare
right,
because they don't have insurance with their employers, or they can't afford to pay out of pocket. And
right.
a lot of those people who voted for this incoming administration, they don't feel like healthcare should be a human right.
Yes. It's interesting also how, and I saw that, yeah, really, I was a bit surprised, but in reading it and understanding about how you really celebrated midwifery
Yes,
and how you saw how this affected yourself.
yes,
And can
yes,
you talk a bit about that and what's happening
yes,
with respect to women and Black women and how sexism and racism plays cuts across class?
yeah. It's so interesting because I was trained as a physician, and I'm sure you probably can imagine when you look at all healthcare disciplines, um, the physicians really are like the know-it-alls. And so, when I would be in the ER working and a baby and a mother would come in from a home birth, the way that my colleagues would speak so horribly about that person, say, what were they thinking? How could they have had a baby at home? Because the way that we were trained, we just think it's in hospital births are the best way to go. But the fact is that that is actually probably the most dangerous one, and two, we don't understand the history. So the history is that even the field of obstetrics and gynecology, or doctors delivering babies, that is the outlier, because who delivered babies in this country were, or not even in this country,
Women.
but even from our ancestors from the continent, are birth workers, right? So and here there are midwives and doulas, but midwives are trained professionals who can deliver babies at home or at a birthing center. About 80% of first time births qualify for at home. You don't have to go to a hospital. And what happens when people go to the hospital, especially Black women, when we go to the hospital, we are not listened to, we're ignored, our complaints are minimized. So, what happens? We're not listened to, then we're also more likely to get interventions like C-sections,
Or
which is
tubal
major, or
ligation.
like, yes, major abdominal surgery. So
Yes.
we are put in these situations that are more risky, that risk our lives. And so that's also why we see a contribution to, a higher maternal mortality rate. We know in countries, other high income countries, that center midwifery care, that also provide postpartum care, because that's the other issue. In this country, you get one or two postpartum visits and you're done. But the fact is two-thirds of maternal deaths happen in the postpartum period.
Yeah.
We don't support people and families. We don't. And we see that in the maternal mortality rate.
that's a whole book in and of
I
itself,
know, I know,
you
I know.
know.
Yes.
So as you think about after writing this book, what is your message to the community, to women,
Yes.
to parents? What message do you have to
So,
doctors and to the
yeah,
profession?
yeah. So, I wrote this book for several reasons. One, obviously, to share with people my own story and about my mom, because she's not here to be able to tell her story. So I want to be able to help share her story with the world. But the other piece of it, I'm a physician, but I've also been a patient. I also wanted to validate and affirm the experiences that we have as Black patients. That yes, I see you. I know that there are many times we feel like we have not been listened to, right?
Yes.
And that this is a real issue, right? And that's why I wanted my white colleagues to read this. I wanted
Okay.
to understand that it's not just our job. It's not just our job. We need their help because also they are part of the problem. You know, the fact is that health professionals are no different than any other people that live in this country. They internalize anti-blackness, racist messaging, and while they may not be explicitly racist towards someone, we do know that it impacts how they make decisions about patient care.
Right. And as you said, they're not even aware.
Right.
It's, this the privilege overrides that.
Yeah. Yes,
Right.
exactly. So I want them to be more aware. And I also feel like hospital systems also need to be held accountable. So I feel like racism is so deeply embedded in all aspects of our society. Like we need to be keeping data metrics on how patients, 30-day readmission rate, who is getting prescriptions for pain medication, who is not, who is content with the care that they received, who is not. What are the interventions going to be? How are you going to be accountable? We need that.
It's
And
are those, and those some of the things you're doing in your
yes,
organization.
yes, that is some, yeah, and that's, I feel like it can feel so frustrating and so overwhelming, but that's like the little piece that I'm going to do to try to make a difference. And actually, it's interesting that you ask for parents because I am actually working on a second book idea.
Okay.
And it really is about centering the needs of Black children
I,
because I feel like, and it's because when I wrote the first book, my children were 3 and 5. I have two boys. And now they're 8 and 10. The older one is entering middle childhood. And when we think about the social and emotional needs of Black children, and then today, what they have to deal with, we know that mental health, depression, and anxiety is going up. They are more likely to be bullied on
that's
social
right.
media. They have to deal with the climate crisis. There is so much happening. So I
And
want,
yeah, so and then as you said, the message to parents and how do you protect children? How do you support them? How do
yes,
you
yes,
protect them?
yes.
I had two sons who were the
I
two years apart too, so
yeah,
I understand it can be a bit frightening. So you have to have some specific
yes,
interventions
yes.
that happen, you know.
It's the first time I'm mentioning it, so I wanted to mention it with you, the second book, because I'm manifesting it. I'm
Okay,
manifesting it.
I love it. So what is the just as we close, what has been the reaction to the book?
Oh my goodness, it's been overwhelmingly positive. I have not gotten a single negative, um, you know, email or note, and I think it's because it is timely, and even timelier now. I think people feel seen through this book, especially our experiences as patients. Black health professionals feel seen because they've been through very some other academicians feel seen. So I think there's a lot that it can people that resonates with people. I also think that it's so important we tell our stories, right?
That's
It's
right.
so important that our stories get out there. So I'm hoping that my opportunity makes the road easier for other authors who come after me.
Well, I thank you for telling that story, and it's also very courageous to tell because you also shared some of your own personal information, and the fact that you're getting the reaction that you're getting speaks to the importance of making sure that story continues to be told. So I thank you so much for having this conversation with me, and congratulations on the book. And I'm looking forward to the book for the children
Yeah, thank you.
around what parents can do
Yeah.
for children, because we have to be very, as I said, very, very specific and really create nurturing and safe environments for our young people
Yes.
who are facing so much more than even we had to
Yeah,
face coming up.
absolutely. Thank you so much, Dr. Greene.
Thank you. So you've been listening to Writers on Writing with your host, Dr. Brenda Greene. I've been in conversation with Dr. Blackstock, and she is the author of the memoir, Legacy: A Black Physician Reckons with Racism in Medicine. Very, very important book. And so again, this radio show is paid for by Medgar Evers College. You can also watch us online. You can go to our YouTube page at the centerforblackLiterature.org, www.centerforblackLiterature. So thank you so much again, Dr. Blackstock.
Thank you.